All right, thanks. I'll be presenting on the Children's Health Insurance Program. That's where you get the corny title of Chipping Away at Health Disparities. And this project is part of a larger NIH-funded project on Mexican children of immigrants. And why we're presenting this paper today is we've been collecting our own data on state differences in their health insurance programs for children, especially with regard to immigrant children. So recently there has been concern in the US about America's relative rank in terms of health. And I put up a few examples from the National Public Radio. The US ranks below 16 other rich countries in health report. And then similarly for the IOM report and the Commonwealth Fund, which is about the US healthcare system. So one of the reasons behind the US relative ranking that has been discussed is the race-ethnic health disparities. And in this paper, I'm particularly interested in the healthcare disparities among children. So I wanted to show a little bit about what I'm talking about. So I graphed the infant mortality rate by country. So I put in the US overall, Canada, since we're in Canada, and Sweden. And also I graphed the different race-ethnic groups to show how extreme the inequality is even today. So it's the IMR for non-Hispanic blacks in the US is more than double the other race-ethnic groups, in addition to Canada and Sweden. So these graphs show the percent of all children and the percent of those 6 to 17 years who did not have a healthcare visit in the past year from 1997 to 2011. And Hispanics are the least likely to visit a medical provider of any kind in a year. And these disparities have gone down, but we're still concerned about health disparities in the US. So what this shows, and in terms of what the CHIP program has aimed to do, is we want to know whether CHIP, the Children's Health Insurance Program, has been responsible for some of these reductions in disparities. And it's also important to consider the years leading up to the Affordable Care Act. So we want to know what measures have worked in the past and where we can take the country moving forward. Okay, so the 1997 State Children's Health Insurance Program, SCHIP, now called CHIP, was designed to sit on top of the Medicaid program. So Medicaid in most states covered children, for example, in New York, up to 133% of the federal poverty line. And the SCHIP program in New York, at least, covers children up to 400% of the federal poverty line. So in all states, it's designed to allow low-income children, but not poor children, the opportunity for health insurance. In terms of immigrants, the federal SCHIP policy was consistent with the 1996 PERWARA, or Welfare Reform Act, that limited coverage to legal immigrant children who had lived in the country for more than 5 years. But states did have some flexibility in implementing their CHIP programs, and some created SCHIP lookalike programs to cover legal immigrant children before the 5-year bar, as well as some undocumented children. So by 1999, all states and the District of Columbia had received federal approval to implement their SCHIP programs. And then also in 2009, there was the CHIP Reauthorization Act, which gave states the option to extend coverage to legal immigrant children before the 5-year residency bar and receive federal matching dollars. So many of them after 2009 did this, whereas previously they had not extended these benefits. So there's been some research on the consequences of S-chip on healthcare disparities among children. There was the Mathematica Policy Institute was the contractor for evaluating the S-chip program. And in the second study here, they found, Kenny, 2007, found that the established S-chip enrollees were more likely to receive preventive health and dental care and less likely to have unmet needs compared to recent enrollees who were previously uninsured. Similarly, Dubé et al. Found that the share of low-income children, so under 200% of the federal poverty line, covered by public insurance did increase from 1997 to 2005 by 14 percentage points. It was 36.6% of children to 50.6% of children. So the thing that we identified in the literature that's missing is what about the immigrant children? There's been very few studies that have looked at the health care of immigrant children and specifically the policies that are relevant to them. So the objectives of this study are to first document that the race, ethnic, and nativity-based disparities in routine healthcare utilization among U.S. children, controlling for health status and the family socioeconomic status. Second is to determine if race, ethnic, and nativity-based healthcare disparities vary by state-level immigrant eligibility policies and which specific policies matter the most. And third is to examine whether these policies work through health insurance coverage for children. So the data collection effort that we've been doing for about a year now is we're trying to collect longitudinal data from about 1995 to 2011, so right before the Affordable Care Act went into place. And we're particularly interested in the immigrant eligibility requirements for their children and their mothers. We don't present it here, but we are interested in the prenatal and unborn child's policies as well. So we've been contacting state health officials in and out of government. I have to say that in the out of government is easier to contact. So we've contacted state health departments, legal advocacy centers for both immigrant children and immigrants. So just as an example, in Illinois, there was the Sargent Shriver National Center on Poverty Law that was extremely helpful, and the Arkansas Advocates for Children and Families. So these are places that we've been contacting and have a better understanding of the longitudinal nature of our data. It seems that in US government, a lot of people come in and work for a year or two and don't know what happened in 1995, especially before the internet. So we've also been looking at electronic data sources, including what I said, the Mathematica evaluation series, as well as charting S-chip surveys from the National Academy for State Health Policy. And these sources have been helpful, but yet again, the immigrant eligibility policy has not been so easy to track down. So what we have today to present to you is the first half of the states in alphabetical order. So it's Alabama to Mississippi, I believe. And of these states, 6 rank in the top 10 for Hispanic population size, and 2 rank in the top 5 for Asian population size. And we're interested in those just because we want to make sure we have a decent-sized foreign-born population to look at. So our state-level policy indicators that we're interested in are the income threshold of the program, so what % of the federal poverty line do they cover? And does the state require documentation of legal immigrant status? This is an easier way to ask, do you cover undocumented children? And third is, does the state provide coverage to legal immigrant children who have lived in the US for less than 5 years? So this generosity scale is, I'm not going to show any real data on it, but I wanted to show some maps that chart the scale. So over time, how have these 4 indicators changed in the US? And I can go over them again if you want, but here you just see the generosity scale from 1998 and 2010. And in general, the scale has, our states have become more generous. So I just wanted to point out, the white is that they didn't have a program yet, and the least blue, lightest blue color is that they had a program. Basically, they have a basic program, and they don't cover above and beyond the basic federal guidelines. Okay, so this is another way to show the similar information. From 1998 to 2010, the number of states that covered the legal children before the 5-year bar increased. And the number of states that do not require legal documentation increased slightly, although, as you can see, Minnesota actually dropped out. And then just this mean score that I created on immigrant generosity increased. So what we want to do is map or merge the state level data to child level data, and we're using the Survey of Income and Program Participation, which has been conducted by the Census Bureau since the 1980s. It's representative of households, families, and individuals, and it is particularly interested in public program participation. So I merged the 1996, 2001, 2004, and 2008 panels of the survey. They all last about 2.5, 3 years. And it resulted in a sample size of 113,000 person years for children under the age of 19. And then we also ran some of our models with just the children who lived in families at or below 400% of the federal poverty line, because those are the ones that are most likely to be impacted by the SCHIP program. So here's some basic descriptives. Really what I want to point out is the number or the percentage of children that did not have a doctor visit in the past year. It was about a third. And then in addition, we used, for the insurance status variable, we used monthly data to create an indicator of stable versus unstable insurance coverage. So about 70% of the sample was always uninsured versus 25% that had some months of no insurance and 6% that were always uninsured. For analysis, we used a multi-level logistic regression model that accounted for the state-level clustering. This was Proclimix and SAS. And the thing about Proclimix is that we weren't able to take into account the survey design of SIP, and we were having issues running the 3-level model. So in the future, we'd like to figure out a way to incorporate our within individual variation as well as the within state. So for our results, we ran 5 models. First, we put in race, ethnicity, and nativity. Then we added the individual and family level controls, followed by the policy indicators and their interactions with race, ethnicity, and nativity. And then finally, we looked at the mediating effect of child's health insurance. Okay, so here you have the results. Overall, even with the individual and family level controls, the race, ethnic, and nativity groups were less likely to see the doctor in the past year than native-born non-Hispanic whites. So I had boxes, but they didn't show up on this. So right around every coefficient except for the first one there. In addition, the native-born non-Hispanic blacks and foreign-born Hispanics were the least likely to see a doctor in the past year. And these were true for both the full sample and the restricted sample. Okay, so for models 3 through 5, we ran it for the restricted sample only. In model 3, you can see we didn't show all the coefficients. There was just a lot. But for the 300 plus income threshold, there was no difference from the reference threshold of less than 200%. And we hypothesized that these children may not be affected by the policy, a more generous policy, because they are able to afford private health insurance through their employer. And also in this model, we see that the no legal documentation requirement and no residency requirement work as expected. So in states with more generous policy, children are more likely to see the doctor. In Model 4, so again, we're showing our significant interactions as well as relevant ones. So compared to a less generous income threshold, Native, non-Hispanic Blacks, Native Asians, and foreign Asians who live in states with thresholds between 200 and 300% of the federal poverty line are more likely to visit the doctor in the past year. As well, foreign Asians who live in states where documentation of legal status is not required are more likely to visit the doctor. And finally, foreign-born Hispanics who live in states without the residency requirement are more likely to visit the doctor. And adding the health insurance indicator does reduce the coefficient for the foreign-born Hispanics. So in that case, the policy does seem to work through the Hispanic children being able to access health insurance. And overall, the health insurance variables are highly significant. And I just wanted to point out the state covariance parameter. So it shows the variation between states, and it's significantly different from 0. In addition, when we add the policy indicators, it goes, so from here it's 0.11, it goes to 0.09, so about 20% reduction in what we have is explaining this between state variation. So looking back at our questions, yes, there are race, ethnic, and nativity-based disparities in access to health care, and the foreign-born Hispanics and native-born non-Hispanic Blacks are the most disadvantaged. 2 is that policy indicators are sometimes significant but do not explain the race, ethnic, and nativity disparities. The income threshold matters for natives and immigrants, especially a threshold that encompasses the near poor, so the 200 to 300% of the federal poverty line. Whether a state requires legal documentation matters for the foreign-born Asian children, and whether a state prohibits coverage of recent immigrant children matters for the foreign-born Hispanic children. In another paper we're working on, we're looking at the Hispanic children only, and there seems to be more variation among those children in terms of the effect of the policy indicators. And finally, 3, among our policy indicators, only the residency requirement seems to work through access to health insurance, namely for the foreign-born Hispanics. So to conclude in yet another corny way, we are indeed chipping away at health disparities, but we need to add the remaining states, so we're looking at half right now, but we are hopeful that these can be reduced further. Thank you.